and my dear students. I welcome all of you for today's auspicious event, the National Science Day. I would like to tell all the young men and women before me not to lose any hope and courage, because success may only come to you after a particular devotion to the task lying in front of you. These are the words of Dr. C.V. Raman, one of the greatest visionaries of science, in whose honor the National Science Day is celebrated. He discovers the inelastic scattering of light, also known as Raman's effect or Raman's scattering, on 28th of February 1928, and was awarded by the Nobel Prize in Physics for his discovery. For his achievement, the Indian government on 1999 declared the February 28 as a National Science Day. In addition to being a recipient of the Nobel Prize in Physics, Dr. Raman has been awarded several honorary doctorates and membership of the scientific societies. He was elected as a Fellow of Royal Society in 1924 and was knighted in 1929. So, for the occasion of the National Science Day, today we have the chief guest, Dr. Pramod Gar. And to introduce our chief guest, I would like to request to come on stage our respected Executive Director, Professor Sudhanshu Vrati.
Thank you, and greetings to all of you on the National Science Day 2022. As the speaker just before me told, the Government of India declared 28th February in 1999 as the National Science Day to commemorate the great finding of Raman effect by Sir C.V. Raman, the only Nobel laureate whose work done in India was recognized for this great honor. This was in 1930, so it's almost like going to be 100 years since India had this Nobel Prize in science, and it's about time that we grow up to a stature where our research gets recognized at the highest level in the form of such recognitions. To bring, to galvanize rather the spirit of science among youth in this country, this National Science Day is celebrated, remembering the great discovery by C.V. Raman, and also encouraging a lot of young people to think of science as their career. So my greetings to all fellow scientists and science practitioners on this campus on this National Science Day 2022. The speaker today, Professor Garg, needs no introduction. He is a dear friend and colleague and closest neighbor that RCB has. At THSTI, he is executive director, as you know, but I don't know how many of you know that. I think a lot of people know that he came from AIIMS, but what did he do at AIIMS? So he is a professor of gastroenterology, and he is a clinical scientist. So we have many clinicians and many scientists, but very few clinical scientists in this country, and Pramod is one of them. Besides doing his clinical practice, he has been responsible not only for THSTI, but AIIMS Raebareli and AIIMS Bilaspur. He is president of these two All India Institutes of Medical Sciences. In terms of his science training, of course, he's trained in situ wherever he studied his medicine, but he has been a visiting scientist to University of Minnesota and CCMB, Hyderabad. Because he's a clinical scientist, we thought that it would be appropriate to hear from him, how research being done on this campus and more so in RCB could find its way into clinic. And let's hear from somebody who practices this. So Professor Garg, thank you very much for accepting our invitation to speak. And I would like to now invite you to deliver your talk on this very important day and very important topic. Thank you.
Good afternoon, ladies and gentlemen. I'd like to thank Professor Sudhanshu Vrati for giving me this honor of talking to you on this very important day, National Science Day, Feb 28. About 100 years ago, India probably had nothing except struggle for freedom. And at that time, if somebody could delve into deeper science and come up with stunning discovery, I think it deserves more than one Nobel. Today we have, I think, almost everything that one could ask for or aspire for in terms of resources, be it high-tech equipment, funds, and I think there is no dearth of funds, at least in India today, or collaboration, and strengths in different other institutions to collaborate. So we have resources in terms of equipment, funds, and collaborating partners, both nationally and internationally. So there is no reason why today we cannot do science which is at the cutting edge. And I think the biggest obstacle that, to my mind, to achieve that success is our own mindset. We often think about what others have done, especially in the West, what has been published. We try to imitate that, repeat that, and think that is the best or that is the truth. But that may not be so. So what we have to do is to have our own original ideas and concepts and test them. The literature, the published literature, the research that has been done by others is there to help you understand. But don't depend only on that. And I'll discuss a little bit about that during the first part of my talk, before I come to the main topic. So I think you have to have a larger canvas to paint on, think big, and think original. That's the most important thing if you have to do good science. And all the youngsters who are sitting there, I can tell you, you are no less than anybody in any other country when it comes to your brains, your mind, your hard work, your sincerity. You need to think big and be disciplined and dedicated to what you want to do. As researchers, I mean, you can do anything that you want. Nothing is going to stop you. So there are two parts to my talk. One is about science and research. The other is about biology and clinics. So there is a very famous Nobel laureate poet from Chile, Pablo Neruda, who said, "Who am I? Why am I here?" And this is what ancient Indian scriptures also ask always, "Main kaun hu aur main kyun hu?" Purpose of my life and who I am. So as researchers also, you have to ask that. Why have you entered the field of science? Why did you pursue physics, chemistry, or biology? Why didn't you do just commerce or some other thing? I'm sure each one of you had something in you that pushed you to do science, whether it's curiosity or a desire to contribute to science. And once you have entered the field, to fulfill that desire, I think there is no stopping you, but yourself only. You may be satisfied by getting a degree, MSc, then PhD, doing a postdoc, and trying to get a job, a few publications, and a grant. And of course, senior, when you become senior, a couple of awards, and you think you're done. I don't think that should be the purpose of life or your career. These are the things that you need to achieve what you want to achieve. Getting a degree, a publication, a post, a fund, a grant, an award. These are stepping stones, not the end in itself. So I think that is what each one of you should understand, remember, and then you will achieve what you want to achieve. So during the Second World War, there was, Russian, right now also Russia is in the news. Winston Churchill said, Russian action is a riddle wrapped in enigma and shrouded in mystery. Very famous quote by Winston Churchill. And he said, perhaps there is a key. Now, when you talk about complex biological problems and issues, the key is research. So everywhere, whenever you read something, you try to do something, you find the answer lies in research, discovery research. And research could be basic, biological, in the lab. It could be clinical. You go to clinic and then see a couple of patients, write something about it. Or translational, you do something in the lab and then translate it to the clinic. And that is what we'll be discussing. So it could be bench to bedside. But often that is not the case. Because you don't know what you're doing, what you are going to discover. It is bedside to bench first. That means you observe a problem. What is the problem? When you observe the problem, you try to understand what is happening. It takes you to the bench. It takes you to the bench, and then you do something and discover, and then you take it to the bedside. So this is how the cycle of discovery and research should go on. So a scholar is someone who acquires knowledge. You are doing your BSc, your MSc, you acquire knowledge, you become a scholar. But a researcher is someone who creates knowledge. And that is why I always keep a researcher on a higher pedestal. Someone may be an excellent scholar, and I respect him because he dissipates knowledge. He teaches others, right? And we have all been, immensely benefited by our teachers and trainers in life. But a researcher is someone who creates that knowledge for the scholar to acquire and disseminate. And that is why I think as a researcher, your job is very, very important. And in a place like RCB, you can do both. You teach, you train, and you do research. Excellent opportunities you have in an institution like RCB. Two problems I will highlight for researchers, scientists. So everybody, whosoever is doing basic science or deeper science, over 10 years, 15 years, what happens? You have your ideas, you have your concepts, you are working, you are publishing. You think what I'm doing is the best. What I'm finding out is the truth. And then we try and do the same thing all over again. So there are two problems that I identify, and I'll tell you the source of these. One is a confirmation bias. You want to confirm what you're doing, what you think is right. So you try to find the evidence to confirm your ideas and concept. And many times you forget what others are seeing, what others are observing, what others are reporting. And the second is the narrative fallacy. So all of us write papers. So when you write papers and you write discussion, what do? You pick up references from here and there which support your findings. And you often don't cite references which are against your findings. That's a narrative fallacy. You try to explain things without direct evidence, either by illogical thinking or deductive reasoning. So these two problems you must try and avoid whenever you do science: confirmation bias and narrative fallacy. And for this, one of the important solutions is being a skeptic. Skeptic is someone who doubts what is known and challenges the dogma. And this is very important in science. If you accept what others have been saying, you may have the same problem that they had without realizing that that is not the truth. So for good science, you should become a skeptical empiricist. So this I have taken from a book called Black Swan by Nicholas Taleb. I would recommend every one of you, if you have time, to read this book, The Black Swan. Excellent book. It's a bit difficult to read, but you should read that. So now I come to the second part of today's talk, how biology is important in the clinics, and are we ready for that? So typically what happens in a clinic, that a patient comes to the hospital, he's seen by a surgeon, for example, the patient has got some abdominal pain, the diagnosis made is of gallbladder cancer, CT scan is done which showed advanced cancer, stage 3, so surgery is not possible. Curative surgery is not possible. A chemotherapy, palliative chemotherapy is planned. Prognosis is told to the patient, less than a year survival, right? Patient receives chemotherapy but dies after 3 months. Median survival actually is about 6 months in unresectable cancer, gallbladder cancer. What does the surgeon do or the physician do? He will collect a series of patients like this and publish a paper. That's the outcome of that. So for example, a paper was published from our institute, gallbladder cancer in India is a dismal picture, and we showed mean survival less than 6 months. Then another study was done. You have hundreds of patients, you do a case control study, collect the risk factors, epidemiological study, and find out what is it that is causing gallbladder cancer. And for example, in this case, you found gallstones, females at a higher risk, mustard oil may be a risk factor, smoking, of course. Then as chemotherapy was given, so medical oncologist will come on board. He will say, okay, let us try different therapies. They will do a randomized trial. For example, this trial was published from our institute, and they showed that gemcitabine may be an effective therapy, right? Survival at best is 9 months, even with best of the chemotherapy. So for a clinician, this is what is done. You see patients, you diagnose, give some prognosis, publish a couple of papers. For the same patient, the cancer tissue was collected by a cancer biologist. What will the cancer biologist do? They will like to make organoids. Currently, organoids are considered very, very important in understanding the pathobiology and also now to test therapeutics. They will also try and collect the DNA and RNA and check quality, and then somebody here will do microbiome and epigenetics to find out what is the mechanism of cancer. They will do a next-generation sequencing, do some library preparation, bioinformatics is brought in, and they identify certain driver mutations and minor mutations. So when this person talks to the clinician doesn't understand. He said library preparation, but there is a library with lots of books in my hospital. What's the problem with that? Why do you want to create a library here? Right? So this person will again publish a paper. So there are a couple of papers published on gallbladder cancer. They found certain mutations in different genes. And I think this was one of the important papers from Tata Memorial Center, where they found certain loci in patients with gallbladder cancer. So what is happening here is that both clinicians and biologists are doing fairly good work. They are seeing patients, they are studying cancer tissue, they are publishing papers. The problem is they often don't talk to each other. And when they do, they speak different languages. He's speaking about 5-year survival, TNM classification. Cancer biology doesn't understand what is TNM, what is this prognosis business. And when he talks about RIN and NGS and bioinformatics and David, the clinician doesn't understand. So they're at a loss of words there. And they think the others area is too difficult to discuss. And that is why there is a disconnect. Now, if you talk about specifically, say, genomics in medicine, Genomics in medicine is extremely important, and I'm sure many of you are doing that. In familial cases, chronic diseases, often there is an important polygenic predisposition in addition to environmental factors. And also now we know infectious disease also genomics play an important role. In cancer, it is all about genomics, right? It's also important disease biology and behavior, and nowadays in disease outcome, and also most important area is pharmacogenomics. So when you talk about genomics, you bring in a cancer biologist. And to my mind, this is hugely important because cancer biologists will tell you about the understanding of cancer development and progression. So I'll give you a couple of examples how this is important to take it to the clinic. So take an example of colon cancer. So colon cancer is very common in the Western countries, but also now not uncommon in India, by the way. So this is how colon cancer might develop. So you have a normal looking epithelium here, colonic epithelium, and this is the normal epithelium. Gradually it may proliferate, there is proliferation, then it further grows, there is hyperplasia, some kind of metaplasia as you can see here, and then it forms what is called as a polyp. This polyp is benign, this is only hyperproliferative mucosa. And then some stage it will turn into cancer. And this is how you can see on endoscopy also, a polyp here and a cancer here, and histology also shows the same. But what the cancer biologists told us is that at each stage there is something happening at a subcellular level. And they showed, for example, in the normal colon, if someone has these mutations in APC or MSH or MLH genes, it may be important for the subsequent development at this stage, where another set of mutations might occur, and then it goes to the next stage. At this stage, you have another set of mutations, say for example, KRAS, P53, and then it turns into a frank carcinoma. So this sequence of events, how a normal cell becomes a cancerous cell, came from deeper biology, from a cancer oncologist or a genomics person. But it takes many years from this to this. And this is how they identified on different chromosomes, what are the genes which are affected, how commonly they are seen, what is their function, whether proto-oncogenes or tumor suppressor genes, or their DNA mismatch repair genes. And then finally a sequence was unfolded. How does it help the clinic? How this entered the clinic? They realized that there is a stage in between which is called as colonic polyp. They showed in the lab how the cells proliferate, accumulate mutations, become a polyp. But at this stage, it is benign. There's no problem. So what they did? Okay, let's look for these polyps. So they got normal, healthy people, found out, okay, more than 50 years or more than 60 years is this age when a patient might develop polyps. They got them in, did their surveillance colonoscopy, found a polyp, for example, here, and you resect this polyp, cut it out endoscopically. No surgery is required. And over the years, now they have shown that this strategy has resulted in significant reduction in mortality due to colon cancer. And this has been now applied to many other cancers. So this is a direct example how basic biology has helped clinicians in tackling major disease problems. So we know cancer develops due to mutations, and this helps now in developing targeted therapies. So you identify, say, 25 mutations. So another thing which has come to be realized now, that you have 25 mutations, they're not all very significant. So there are a couple which are known as driver mutations. They are the ones who drive the cancer formation. There are others which are helpful. They are also required, but not the key mutations. So the driver mutations are known as the actionable targets. If you have actionable target, you now develop drugs again from the lab. And now we have excellent drugs against many targets. For example, EGF mutations in lung cancer, CKT in chronic myeloid leukemia, and another thing which is GI stromal tumors. So in chronic myeloid leukemia, it was found that tyrosine kinase activity is very important for the development of chronic myeloid leukemia. Chronic myeloid leukemia is a blood cancer and which is very common, by the way. And then they developed a drug against this target, which is known as imatinib. And I tell you, this is so effective that now CML today is considered a curable disease in the sense it becomes chronic. The person will keep on taking this drug for years together. The disease is gone, just like diabetes or hypertension. You take a tablet a day and you are fine. Excellent progress has been made of finding out such targets and developing monoclonal. And the next stage was when cancer immunotherapy was developed. It kind of revolutionized the whole thing. Melanoma, the first paper on cancer immunotherapy was published in NEJM about, I think, 15 years ago. They showed a patient with metastatic cancer all over their cancer deposits, given immunotherapy, an absolute total remission. And you know about this cancer immunotherapy. Targeted biological agents are being used. And now you have what is known as CAR T-cell therapy, where you take patients' own T-cells, immunize them with the cancer antigen, reinfuse them, and now they are the killer cells which will kill the tumor cells. Because tumor produces something which prevents your cytotoxic T lymphocytes to act on the tumor. The tumor is smart. Tumor cells are smart. So how do you counter that? You take the lymphocytes, prime them with the antigen, infuse them back in, and now the tumor is gone. And this therapy, although currently it is very, very expensive, it costs about $1 million for one treatment, but it is coming out to be very effective in acute leukemias, those who are resistant to all kinds of chemotherapy. And now this is being extended to even solid tumors also. Another area where biology is very important is personalized medicine. We often talk about personalized medicine. So what is being done? Someone has a tumor. So the oncologist doesn't know which treatment to use, which drug to use. You have a plethora of chemotherapeutic drugs available. So you take a small piece of the tissue when you do a biopsy, or you have resected the specimen, you have the cancer tissue with you, take a part of it, xenotransplant in nude mice, check the mutational profile, and now test those drugs. And this is no more a fancy idea. It is now being used. And then after a month, when the patient is ready for chemotherapy, you have the results with you. You start the patient on that particular chemotherapy. So how do we leverage this great advancement? We need stronger collaboration between clinicians and biologists. So how do we bridge that gap? I would say much is already happening. So Tata Memorial Center in Bombay, they have this ACTREC, Advanced Cancer Laboratory. Very big institution. They collaborate and they are part of each other, sister organizations. So it is happening in many other places, but not much. What we need to do is for clinicians to have some kind of basic science training. So there are clinicians who will be practicing, seeing patients and doing good, and I'm absolutely fine with that. I mean, they are the ones who are the backbone of the healthcare system in this country, or for that matter, all over the world. So this is very good. But if someone wants to do some research and get into an academic institution, I would suggest that you get now some training in basic science. Otherwise, you won't understand what is happening all around you. I mean, you want to confine yourself to basics, to clinical practice is absolutely fine. It is what is required. But if you do intend to become a scientist or a researcher, get some knowledge in basic science, which is very important, and learn their language. So, for example, I work in a disease called pancreatitis. I had to understand the pathophysiology of pancreatitis and try and do some experiments. So I had to go to a basic science lab, learn the experiment myself, and then we found something. So for example, we found oxidative stress in the SNR cells of pancreas is an important mechanism for producing inflammation in patients with chronic pancreatitis. And this resulted in a therapy of antioxidants, which we published many years ago, and it has now become a part of standard therapy for these patients, where we showed antioxidant supplementation help reduce the inflammation and pain in these patients. So this is how you have from clinic to bench and back to the clinic. For a basic scientist, I think you should develop more collaboration with your clinicians. So often what happens, you have a collaboration, you ask your clinical colleague, यार वो sample चाहिए थोड़ा सा, 5 ml blood दे देगा आपको नहीं यार वो कैंसर का टिश्यू बचाना चाहिए, लैब में भेज देना, मैं दे दूंगा, और ओटीएम भेज देना दे दूंगा. That won't suffice. You are still in your silos, you're still working separately. You should discuss jointly. Research projects, have combined research projects, and I think some of you have that. But I think more needs to be done here. One of the very good things that we have found is giving joint PhDs. You have a guide as a clinician guide and a basic researcher guide, and they both will talk to each other. And a protocol is developed where the student has both clinical component and a basic science component. And I'll give you examples. I'm not talking just like that. So my PhD student, Shalu, actually worked on finding out the reasons for chronic pancreatitis. So in India, this disease, chronic pancreatitis, was known earlier as tropical pancreatitis because they thought it occurs in tropics, so let's call it tropical. They thought it's a disease of malnourished young people who have diabetes. They die very early and probably occurs due to malnutrition and cassava, because it was seen first time in Kerala, where they eat this tapioca, is something like a sweet potato kind of a fruit. But we didn't see that. We never had patients who were malnourished, who were diabetic, and they never ate cassava. And I said, look, here is a disease which looks like the same, but none of these factors are present. So either disease is different in Delhi than Kerala, or something else is happening. And this was at a time when some basic science research showed that genetic mutations might be involved in the pathogenesis of chronic pancreatitis. So first time they found it in hereditary pancreatitis, which obviously has a genetic basis. But then there was a paper from Hyderabad where Dr. Chandak showed that SPINK1 mutation is present in patients with chronic pancreatitis. Simultaneously, another paper came from SGPGI. And then we also found the same thing in our patients with SPINK1 and CFTR mutations. And we showed there are different pathophysiological mechanisms, not just what was reported in 1970s. And I can tell you, who is a basic biologist or basic scientist, now can treat patients with chronic pancreatitis to the extent that she sits in the clinic, she sees all the patients, enrolls them in study. Now, obviously, she has done PhD and everything, but she understands both now basic science as well as the clinical part of it. She's not treating patients. So and then she published another paper on chronic pancreatitis and how it leads to cancer. And again, we found that there is a genetic basis for this transformation from a chronic inflammatory state to a carcinoma. Another student of mine, Kajal, she actually worked on gallbladder cancer. So I showed you that cancer progression in colon cancer. Now, similar thing she showed in gallbladder cancer. So one of the risk factors I showed you was gallbladder stones. But we don't know whether they actually develop stones and then cancer, or a cancer patient has also stones associated, not the cause. So how do you study that? So what we did was, we designed a study where she took all patients who were getting operated for gallbladder stones, took their gallbladder, processed the entire gallbladder specimen, and looked for preneoplastic changes in the mucosa. And she did that in 350 gallbladder specimens. And she found hyperplasia, dysplasia in 32 and 15%, and 1% she found cancer. And also, she found that there is a sequential accumulation of these genetic mutations, what we call as loss of heterozygosity, at each stage. So you have early stage of metaplasia and later stage of dysplasia before cancer develops. So at stage of dysplasia, multiple mutations were found. That kind of showed that indeed, if you follow these patients for 10, 15 years, they might, some of them, not all, some of them might develop cancer. So this is how I would say that a clinician and a basic scientist can have joint projects and come out with very good studies. So we obviously need close association, understand and trust each other. That's also important. Identify the research question together, form a team to crack this problem. Now, trust is very important, and also giving to the other person. You get a grant, give the money to the other person. Give authorship to the other person. Or you have an issue, right in the beginning, discuss about it. Because later there could be problems. From an institution point of view also, I think the leadership should take this initiative. They should encourage, enable and enhance cooperation between basic scientists and clinicians and acknowledge equal contribution, whether it is a paper, a patent, or even a patient. Because a doctor sees the patient, he gets the credit, basic scientist doesn't. But today is the time the basic scientist must get credit. And this is possible. So this is my last slide, which shows you a typical tumor board. You have a clinic, patient is at the center here, you have an oncologist there, you have a surgeon, you have a radiotherapist, and you have a radiologist. Patient will come, they will diagnose based on radiology, surgeon will decide about whether or not surgery is required, oncologist about chemotherapy, radiotherapist about radiotherapy. I think it is about time that a biologist should sit in the clinic. This is quite possible because today, if he has to take that cancer tissue, he will tell the oncologist or the surgeon when does he want the tissue, how does it want it, in what vial, how much tissue, how will he process, when he will give that information, how will he process for the sequencing and mutations. So I think there is no reason why cancer biologists will not get the same amount of credit as the clinicians would do. With this, I'll stop here and thank you all very much for your patient listening.
Very lucid talk and
Pleasure.
with some examples. This is very useful. So are there any questions? There may be some questions
Yes,
that
there is.
people might have. Yeah, Sunny, go ahead. You can yell out.
Hello, good afternoon, sir. Sir, my question is, sometime I watched the YouTube video also, if I watch the same talk from a Western scientist, either from the US or UK, they will always include the population in this section also. They will include the race part, gender part, age into this, the same kind of studies. But if I frame a framework in my mind, there is a population also with the bench to bedside, and somewhere the population comes also. But in the India, as we can say, we can take the sample from the normal patient and the normal population, the patient. So do we really require to take the consideration of the population into this, or they have the more money, that's why they are considering going for those?
So I think important question. So population definitely comes into play. So when I say this particular risk factor causes disease. So I showed you an example of gallbladder stones may cause, not causing, may cause gallbladder cancer. I can make that statement in India, but I cannot make that statement in the United States. And I'll give you stats. In India, the gallbladder prevalence is 5%, and gallbladder cancer is up to 20 per 100,000 population. In United States, the gallstone prevalence is 10%, double that we have, but the gallbladder cancer incidence is 2 to 3 per 100,000 population. Gallstone there, gallstone here, but cancer is much less. Why? Population. What do you mean by population? When you talk about population, one, you are ethnically different. Ethnically different means your genetic makeup may be different. One, your dietary preferences are different. Your environmental exposure is different. So there are many other variables which come into play other than the major risk factor that you are trying to study. Right? So population from that point is very important. So when we do these clinical studies, when I say we did a case control study, it is applicable to North Indian population, not a North American population.
Any other question? I have something that
Please.
I would like you to comment on. In US, you go to biology departments. Of course, in the clinic, you will find a lot of MDs running the labs. But even in the biology departments, there are MDs, PhDs, MD, PhDs who run the labs there. And many of them are MDs and not running clinic, but they're still running good biology labs. This is absolutely rare over here. So one thing that I have observed, I think there is a cultural inhibition over here. यहाँ एक ये सोचते हैं कि ये डॉक्टर बनने के बाद ये क्या कर रहा है ये, wasting his time. You being the doctor and you getting into this research thing, what are your thoughts, your observations on this?
So I think, again, very, very important point you have made. So, there is this stream of MD, PhD. And in US, for example, many of these MDs who are doctors, they start out as physicians and doctors to see patients. And then they think that research is very important. So they get into both clinic and research, establish their labs, and they have had basic science training. In fact, all doctors there have 1, 2, 3, 4 years of basic science training. That's very important. And some of them realize, look, this is very important. So when they apply for a grant, they build up their basic science component and a clinical component, and they do both. But some of them realize, no, I'm seeing a patient here, I'm helping one patient. If I find something which is really, fundamental, I might help hundreds of thousands of patients. So that is the reason why some of them actually confine themselves to biology only, because they realize the importance of basic science. But in India,
I understand.
One is that their training is...
No, doctors are awfully busy in the clinics.
But that is one part. But the other part is training. As doctors in MBBS, we don't get enough training in basic science. And then you do MD and MS, you are then only doing that. So you are scared of basic science. Actually, that is the case. So you invest a lot of time to do this. At least 3 to 5 years in your formative years.
When I saw that you went to CCMB to train, I said he wanted first-hand.
Because I didn't understand anything.
First-hand experience rather than इसका कुछ NGS कर दो.
अब इन लोगों से बात करता हूँ अपने वो तभी तो बात कर पाता हूँ, नहीं तो कहेंगे छोड़ो आप कुछ नहीं कर रहे, हम बताते हैं, सब बढ़िया चल रहा है हमारा, बहुत अच्छा है. तो इसलिए बात ही नहीं, तुम बात ही नहीं कर सकते इन लोगों से.
You have first-hand experience of
Yeah.
It's very different. So, last chance to ask any questions. Yeah.
Be the difference and can be there in the thinking of a person who has done MBBS and then he went for PhD in biology, and the one who did his PhD and then went for MBBS. So what kind of change they can bring to the clinics?
So I would say both can make the change. So it is rather easy for someone to do MBBS first and then go to PhD. There are some examples of that in India. And I think the trend probably is catching up that there will be a MD, PhD. So you have done your basic MBBS and MD, then simultaneously do PhD. But the other way around is rather difficult. The reason for that is if you have done your PhD for about 5 years and you are already 25, 26, or maybe a year or two older, it becomes very difficult to compete and get into a medical school. So the other stream in India is rather difficult, possible but difficult. But I think both can make the difference, what we discussed today.
So can some steps be taken to make these things flexible for a PhD student to enter?
I mean, sure, a PhD student to enter is always possible. The only thing is that you are most people in India consider them to be too old to get into medical school. I mean, if you enter medical school at the age of 25, 26, you will find that your batchmates are 18 years old.
Yeah.
So that's a problem. In US, I think it is not that much of a problem, but in India it is.
Because if that thing is made flexible for a PhD, obviously what you talked, it can reach to a magnificently.
But I tell you, the shortcut to that is if you've done your PhD and you enter into collaboration with the clinicians, go to their clinic and sit there. They'll be very happy. And over 2 to 3 years, you will learn everything that you need to learn. You don't have to really go and treat the patients, but you will learn enough clinical medicine which will help you in your research. This I can guarantee you.
Can we expect these kinds of changes in upcoming year for the students like us?
No, it is already there.
In this institution?
Yeah, of course. Your boss is here. I mean, if you want collaboration, he'll be very happy to help you out.
Yeah.
So Harsh, some beginning has been made in these directions, not necessarily by us. Indian Institute of Science is going to start MD PhD program. You know, there are issues from Medical Council of India also getting used to this new style of training and creating, you know, research-minded doctors. But this will happen slowly. It's happening. MD PhD program at ISC in next couple of years. I hope it starts off and I hope it's real MD PhD and they don't end up only, you know, a more advanced version of PhD and no MD kind of training there. I don't know how this will happen, but they would need a hospital, and they have money now to build a hospital. Yeah, but you know, I read somewhere that the hospital may end up treating AIMS student and faculty, and you know, not necessarily conducting research in clinic. But let's hope a beginning has been made. IIT Kharagpur, I think, has already.
They already have a medical school.
So these things are happening, Harsh.
JNU is planning.
JNU will have. JNU will have. Yeah, they will have a medical school.
But you don't have to wait for that. You already have a collaboration with many hospitals. I mean, you can always go and collaborate with them.
Yeah. I mean, increasingly this is happening, but again, I find, I mean, I can give you examples of our own NII, THSTI, RCB, etc., where there is a lot of opportunity for our researchers to start, you know, thinking laterally. They are doing fantastic biology, but if they start thinking that how this research can be molded to answer a clinical question, they might have some vague ideas, but then, as Dr. Garg said, spend time in clinic, go and sit there and observe and see, you know, what are the real challenges that they face. And if you keep talking to those doctors, you start also understanding their, you know, clinical language. And you teach your biology to them. This is the only way to start collaborating and get this thing going. Yeah.
Short-term training courses for basic clinical researchers who have pursued PhD or under the process of pursuing PhD for short-term in clinical research areas. Like if somebody is working on say cancer, so if there are certain clinical short-term courses which he can pursue during his PhD or post-PhD, which will make him more independent, and rather than, you know, depending on a clinician, he can get his own understanding of the disease.
So I think it's a very good suggestion, and it is possible. It is doable.
Yeah, because we really don't see such short-term courses.
So I agree with you that there are no such courses, but it is possible. But an easier way is that I told you, you develop a collaboration and go and sit there.
Yes, sir.
The moment you sit and see patient yourself when the clinician is seeing, it is the best way to learn. And during PhD, if you have such a project, which involves, and I think most projects involve some kind of patient sample, rather than just collecting the sample, you be there.
Yeah.
I think that's what I would advise the youngsters.
That is under expert guidance, that would be better. Yeah. Thank you, sir.
Yes, over there.
Good afternoon, sir. Lisa. Sir, my question is very general. Great discoveries comes from great ideas. But talking about ideas, it's, you know, very difficult for us to discuss in a group. Some people afraid that if we share our idea, it will be snatched out. Some people afraid that it might be, this idea won't be that great to discuss over in a group. So how could being a student, we should discuss a healthy discussion among people about our own idea?
You know, somebody say it is good to remain silent and be thought of as a fool rather than open your mouth and remove all doubts. So that is the reason why most people remain silent. But I would suggest whenever you have an idea, go and discuss with whomsoever you can. So whatever idea you have, if you're doubtful about your idea, you read literature and see if you're on the right track. Discuss with your peers and your seniors, and I can tell you someone will find merit in your idea and encourage you to do that. But often what happens, we have an idea, but we keep it to ourselves. We don't think that, you know, it is very important. We are afraid. Don't be scared of that. Make sure you are on the right track by reading literature and discussing with multiple people. Somebody will be there to help you out.
All right. Don't have any more questions. So thank you very much, Pramod, for this very lucid talk. Thank you. I have a very small duty to perform. We have a small memento for you. This is a plant that you can water and remove that. Thank you. Please continue. Only gold plated, it's not golden, unfortunately. Thank you.
Thank you so much, Dr. Pramod Garg, for this great talk. It was really enlightening and thought-provoking. So with this brings us to the end of our Science Day session. I would like to thank our organizers, the IT team, and all the members of the RCB who have made this program possible. We now request all of you to please join us for the high tea outside. Thank you so much.